going back in time, but the very first study that I did as a clinical scientist was a population-based study of intracerebral hemorrhage and subarachnoid hemorrhage at George Square in our Greater Cincinnati area. And I was trained in epidemiology and biostatistics. And at that time, it was unusual to be a clinician who actually had the training. Now a lot of people get that. But it's interesting that I started out with actually a population-based cross-sectional incidence study, because that's actually the first fundamental question you have to know the answer to before you decide on what type of design of study you're going to do. Because if you don't know how common something is, and you don't know how it varies in the population, it's going to be hard to choose the right type of study design. So that's what I'll preface my talk. And George covered a lot of some of the details, anything about how to do studies. I think it'd be nice. We'll have a different overlap, a little different message, but hopefully the combination will be useful for you. You have to use the computer. That is good. So I'll go on the control. There we go. All right. The first thing is to start a little back and just say the scientific method before we talk about design. The scientific method really starts with an observation. You see a patient and say, are those two things going together? Are they related? Is that real? And that observation is really the genesis for any study. And then you do have a hypothesis, and you say, well, is this really true? You formulate something of this relationship, and then you have to test it. And you can either do different types of experiments. One type is an intervention. One is an observational experiment. But this is the process of the scientific method, whether you're in a laboratory setting, working with mice, but also if you're in the setting, in clinical setting. And usually, I would say many of the clinical observations get moved into the laboratory, although sometimes laboratory observations get moved into the clinical setting. An intervention, randomized controlled trials, is really the gold standard because it can address causality better than any of the other designs. And this can be done because you have uniformity of diagnosis in terms of treatment, and you have a defined intervention that you're talking about. You have laboratory definitions, and it's done in a very regular way. Data is collected in a very regular way, and that's why it works so well. And most importantly, as George pointed out, that good randomization cancels out those confounders, which can either make something appear like it is positive, or can actually hide something which is truly a positive relationship and causal. And we don't know all of the confounders. That's the primary thing. There's many things that we think we know, but we've found out over time there's many things we often don't know or can't measure. And randomization helps take care not so much really of the known ones, which we can kind of do in case control and cohort studies, but it's the unknown ones which kill us. There's also things that you can't do in a randomized trial. It's just not ethical. So it's not ethical to randomize people to smoking arm anymore, particularly that we know smoking is so bad for people. And let's say you were going to do, though, a study where you randomized people to smoking or non-smoking and looked at the incidence of subarachnoid hemorrhage. Well, the incidence of subarachnoid hemorrhage is 1 per 100,000 for women 35 to 54 years of age. And even if you could do a trial and with the smoking increased the risk by 10 times, a really big number, you would need a huge sample size to gather about 20 cases. So not only are certain questions cannot be addressed from an ethical standpoint, they simply can't be addressed from a feasibility standpoint with a randomized trial. Which then brings us to the concept of association. George already talked about this. We'll explore this in a little more detail. But association usually defines that two factors occur together more often than expected to by chance alone. For example, African Americans have a higher rate of stroke than whites. Well, is that really something related to being African American? Because skin pigmentation does not appear to be mechanistically or causally associated with stroke. However, this association is likely a confounder for some other factor, whether it's hypertension, whether it's a type of gene, certain gene set. But the point is that African Americans do have a higher prevalence of salt-sensitive hypertension and untreated hypertension. And these factors are not only associated with stroke, but are mechanistically related, because we know from randomized trials, if you control hypertension, you decrease the risk of stroke. So, here's an association. I'm sure most of you know that if you go into any kind of restaurant or bar, you know that caffeine use is highly correlated with smoking use. The two behaviors go together. It has to do with putting things in your mouth and putting two types of drugs, right? So they go together. And so, if you looked at the relationship between coffee drinking and lung cancer, you will find an association. But it's not coffee drinking per se, it's the smoking, because smoking is both related to lung cancer and coffee, and so it's a confounder. And the true relationship is between smoking and lung cancer. But if you didn't know about smoking as a risk factor, and you started kind of from scratch, and you noticed that people that drank coffee got lung cancer, you could assume it was the coffee, if you didn't know about the other confounder. And cohort studies is what George focused on. And cohort gets its name because of cohorts of soldiers, or phalanxes, with 300, 600 soldiers who moved together in combat. This idea of going on a campaign, George talked about the fact that if you're going to go on a campaign, there's a whole lot of logistics you've got to prepare. You just don't walk out with a bunch of guys out the gate. You have to do a lot of planning to know where you're going and how to prepare for that. And what happens here in a cohort is you're exploring the relationship to what you start out with, an exposure to a disease that can be measured. And if you want to use the analysis of a battle, let's say you had a cohort and half the people, or let's say a third of the people, didn't wear helmets. They just didn't have enough money to form helmets. And the other two-thirds, they had helmets. And then they went into battle, and you see who survived and who didn't, the outcome. That is a cohort study. So you start with the exposed and the not exposed, and you end up with the outcome, the disease. In this case, would be dying in battle, but let's say if it was a study of, like regards, the stroke or cognitive decline, where you know the exposure to start with, you know you're free of the disease, of the outcome, you're still alive in battle before you go out and die, but then you follow up on what happens. And there's a lot of advantages to this type of design. They differ, though, in randomized controls in that in a randomized control trial, the randomization controls for confounders, as George already said. And cohort studies can still have confounders in the exposure versus the unexposed that you can measure and know about, but also ones that you haven't measured and you don't know about. But, as he also pointed out, it determines the direction of a relationship, because you started out with the exposure and you ended up with the outcome, rather than you have an outcome and exposure and what's the relationship. So you have this clear directional relationship. They also allow uniform definitions in testing at the very start. That's a huge advantage. Now, one problem with the cohort is that they change behaviors because they're prospectively followed. Let's say we're doing a study on, let's say, the relationship of smoking, okay, to some type of disease. And in the trial, people are being studied and they say, I wonder if there's a relationship between smoking and disease. I think I ought to quit. So you may actually have people changing as the cohort goes forward. And then you get attrition of subjects. I don't know if you've ever seen one of the great pictures of, it's one of the great visual descriptions of data that there is, about Napoleon's march into Russia and back to his home base, and you see the attrition of the army as it goes back and has different things happen. Well, in a cohort study, you have attrition. One thing, people die. Other things, people can drop out for different reasons. So attrition is an important part of a cohort study. It's not very useful for rare diseases. Remember I said you have to know the prevalence and the incidence of the disease to start in order to choose the design of study you want to do. And they're very expensive. They're not much different in cost from randomized trials. An example of stroke cohorts are the Framingham, the Eric, the Rotterdam, and Regards that George talked about. Now you can also do what's called a retrospective cohort. And an example of this is actually from where I trained in Rochester, Minnesota, where you have a cohort, they have the whole population captured all the way back, let's say, to the 1940s and 50s. And you can say, okay, I'm here now in the 1980s or 70s, and I can go back and I have this cohort of people that I'm following through the population over time, and I see what happens, and I'll set up some hypotheses about this cohort and follow what happens over time. Now the problem is, you didn't start the study back at the beginning, so things may be recorded in the data that are not uniform in testing. You may not have all the variables you want, but you can look at maybe certain risky behaviors. It's less expensive and time-consuming than a prospective cohort. So, the summary for cohorts gives you direction of relationships. You can look at multiple exposures and multiple outcomes. George talked about stroke and cognitive decline in regards. It's best for common outcomes, and you can use it for a high-risk cohort for rare ones, but that takes a special type of study. It's expensive and time-consuming, often rivaling randomized controlled trials. It may change methodologies, investigators, and populations over time. And George tells you how long it takes to get one of these started and follow the patients to have the cases. You better have a succession plan in your leadership because your leaders may not make it to the end. And even if you look at the Framingham study, there's been changes over time. And then you can look at both risky behaviors and observation effects. So, there's another type of a process called a cross-sectional studies, where you take a population of subjects at a given time point and you determine the prevalence of risk factors and conditions in the population at that point in time. And what we're looking here is at association and prevalence, but not causality. It's hard to do causality or even direction of effect with a case control study. You would want to have uniformity of testing or definitions. And there's many things that will affect the prevalence of a disease, which I've listed there. So a case control study is where you gather a group of the people with the outcome, the stroke, let's say for example, and a group of non-stroke, non-disease individuals, and you see which group had a higher exposure rate in the past. As the cohort is going out, you can look upon it as it's sort of the retrospective scope of what happened in the battle of the case control. So you start with what happened, the outcomes. And then you go backwards and you say, well, who was exposed? Who wasn't wearing their helmet? Who was? And that's the principle. Now you can see there's some limitations about that process. You have some potential biases that can creep in. But it's the best way to study more rare diseases because the incidence rate is so low. You can collect a lot more cases retrospectively and then go backwards. It allows for a larger number of cases to be identified with less cost. And with more numbers, you have more power to look at significant association between factors. And ideally, though, you've got to get all of the cases in a defined population. Otherwise, you're going to be subject to many potential biases. So, the control group, you have to be careful because people who participate when you call them on the phone or you go door to door, usually better educated individuals are more likely to enroll in studies. These individuals may have better health care, higher awareness of risk factors and treatment, and persons with a special interest in disease may be more likely to participate. Maybe they have a family member who's involved, which could give you an artificial diminishing of family relationships. And spouse and relative controls are another way of doing case control studies, but they may share the risk factors and may not be representative of the general population. So one way you can get a good representation of controls from a population is what's called random digit dialing and other survey techniques. Part of the problem is that now with cell phones, there's ways still you can do it, but it became much harder than it was with everybody had landlines. Now I guess the one advantage is that more people in the population have a phone now. In the past, maybe a lot of them didn't have a phone, and they would only a limited number had landlines, but it's hard to get in a random way to access these patients. If you have a good response rate, greater than 50%, you get a pretty good representative group of controls. And George talked about matching, and matching can help you control for certain variables, but also in a sense can induce bias in the study itself. So, what's the ideal case control study? All cases in a defined population, and then representative controls, disease-free from the same population as the cases. And then you can match. If you match, you can't study the individual effects of these factors such as race and age. Now, one versus many outcomes. Cohort studies can look at multiple outcomes. They can look at stroke and cognitive decline. Case control studies should properly only examine a single outcome, the entry for a case, for example, spontaneous intracerebral hemorrhage. Otherwise, you're just doing a separate case control study. You should not be having two outcomes in one of the studies. So in a case control study of stroke, you can't examine the risk factors for diabetes among the stroke cases. There's some issues with errors that can creep in, and things we can measure and things we can't. One is called recall bias. Remember, we have to remember about exposures. Well, there may be certain things that may make it more likely for you to remember. For example, in a case, you may remember that grandma had a stroke and grandma smoked. In the control, you may not have somebody to remember that relationship, so you may not recall it as well. You can have misclassification. Well, I think grandma died from a stroke. Well, grandma really didn't die from a stroke. She died from sudden death, which was due to heart disease. But at that time, they weren't aware about that 30, 40 years ago, and you don't have the death certificate, so you misclassify it. You may have lack of uniformity in exposure. People can go off and on over the years, and even in duration. And most importantly, you can have lack of uniformity in your definitions. You also lose cases in the population because they never saw a doctor, so they weren't diagnosed. They had their stroke in Florida on vacation, so you never picked it up when you were looking at it in the population in that period. They weren't diagnosed correctly. They died, and so they died before they could get the diagnosis made. And then the remainder are available for study, but that means you have a biased and a non-representative sample of all of the cases, let's say, of intracerebral hemorrhage. So let's give you an example of two diseases and how one design is better than another design for answering the question. So let's say we have multiple sclerosis, and I'm interested in the effect of a drug, okay, on a decrease in 10% in the exacerbation rate. I know, and this is because you have the knowledge about the prevalence of disease and how it acts, that there's 2 exacerbations per year per person in MS, and you want to get down to 1.8. You would get 2,000 events in 1,000 subject years with a 5-year study, and you need 200 patients, essentially. So you can do this in a randomized controls trial. What about ICH? Let's say we're now going 10% difference again, but we're going from 20 to 18 per 100,000 per year. You need 100,000 subject years to get 20 events, and for a 5-year study, you need about 20,000 subjects. That's bigger than any stroke trial that's ever been done. So you can see why this would not be something you could look at if you're interested in some kind of factor related to incidence of intracerebral hemorrhage. You couldn't do it in a randomized controlled trial with that type of effect size. So the cost-benefit ratio, though, is that randomized controls trials are very expensive, $2,000 to $18,000 per patient for recent stroke prevention trials. The cost per subject of observational studies are much cheaper, generally $400 to $1,000 per patient for a case control study. So observational studies, they're not only necessary for hypothesis generation, but sometimes the only ethical, practical method of obtaining necessary data. Without observational data, you can't justify expensive randomized controlled trials, but you got to know the limitations of these observational studies. So how do you do it? First of all, you have to carefully define the disease. That's maybe the most important thing that you will do in any study. And you use the literature, standard definitions, and you've got to be rigid, and sometimes you have to even grade it. Definite case, probable case, possible case, not a case. And you gather as many definable data points as possible, but make sure for each data point you're collecting, you again define very carefully how you're collecting and what that data point means. You need your team, as George said, and I would suggest that you all become very good friends with biostatisticians and data managers. And if you don't, you can search the internet. I'm a statistical consultant. You can look at your local biostatistical department. But unless you're trained in biostatistics and you do it full time, don't assume that you're going to do the job well. And even if you can speak the language and you've been trained, it's good to have someone who does that for their job. And that will assist in the power of sample size, study design, analysis design, and the analysis itself. You want to make sure that you have good data quality, as George talked about. That, if you have garbage in, it's garbage out. You've got to plan for that and monitor that while the study is going on. And you want to make sure the data is valid, because if you get the wrong answer and you repeat it, it's still wrong. So you've got to make sure the data is valid. And what we're doing with observational studies is looking at trying to find risk. And we use the term relative risk in a cohort study. It's the risk of the exposed versus the unexposed. In case control studies, we use an odds ratio, which is an estimate of the relative risk. It's not a relative risk. And again, you have to make sure that's not the same. You understand that. And when you present it, it should not be presented as a relative risk, which I've seen before. And also an important number is the attributable risk, which is the number of cases that would have been prevented if the risk factor didn't exist in the population. And to do that, you have to know the prevalence of the risk factor in the population. So let's take an example. Hypertension, diabetes for ischemic stroke. You see hypertension, diabetes have an odds ratios in a case control study, 1.7, 2.7. The attributable risk for hypertension is 27%, so 20% of the cases could be attributable to hypertension. Diabetes, 21%. And so the odds ratio tells you what your risk is if you have that factor compared to someone without the factor. And the attributable risk tells you how important the factor is on a population scale. So intracerebral hemorrhage, I've already mentioned, it's the ideal for a case control study. The incidence rate is relatively small compared to ischemic stroke. It's only 15 to 30 per 100,000. And you see the incidence of other neurologic diseases. And when you're doing an ICH case control study, your definitions of the disease are critical, because intracerebral hemorrhage is not just one disease. It's multiple diseases, and we have a definition of by location, lobar hemorrhages, and deep hemispheric locations. And that, you'll see how that's important in looking at risk factors. We can also do cerebellar and brainstem, but we have much smaller numbers of these. So here, you can see that this is the percent of ICH by locations in different populations. And one of the first things you see is that not either there's fundamental differences in the location of ICHs in these populations, or the imaging definition varies. So that's why the definition, and making sure your definition in one study is the same definition in another study, is very important. It may even mean rereading the images to make sure they're the same. We also look at the incidence rates of the different types, and we can see that deep is the most common, and lobar is next, but it'd be hard to do enough cases for brainstem and cerebellum to do a separate analysis of those type of hemorrhages. We also see here, if we look at risk ratios, and this is from a population study, a cross-sectional study, incidence study, that you see that blacks have much higher rates for all of the different types of locations except for cerebellum, and that men and women are similar except for the deep, where men have a little bit higher incidence rates. And you see here that blacks have higher rates for whites across the age range up until you get past age 75. And you see that's true for deep, and it's as deep as well as for lobar. So here's an example then of a case control analysis. We're looking now just at whites, multivariate, and we're looking by definition of non-lobar and lobar. And you can see that the risk factors vary by the definition. So that's why it's important to know the disease that you're studying. And the reason probably is in lobar ICH, many of the cases are due to amyloid angiopathy, which we don't, unfortunately, until more recently have imaging that helps us make that diagnosis, whether most of the non-lobar ICHs are probably due fundamentally to hypertensive vasculopathy or small vessel deep arterial disease. And we see when you look at attributable risk, it's also quite different between the two locations. The last thing I'm going to talk about is a newer concept, and it's called propensity scores in observational studies. And we'll take an example in case controls. And it's trying to make the case control or a cohort study more similar to a randomized trial in trying to balance for the risk factors that we think are related to the occurrence of the outcome. So in this case, it's the probability of a unit, a person, being assigned to a particular treatment or particular factor that we're interested in, given a set of observed covariates that we know are associated with the outcome of interest. And propensity scores are used to reduce selection bias by equating groups based on these covariates. So how you do this is you take the outcome data and you hide it. So you don't know which is cases and controls. You kind of blind between those two groups. And you do it till the design phase is complete. And then you list all the covariates besides the one you're interested in that are related to let's say, intracerebral hemorrhage. So let's say I want to say I'm going to look at the effect on statins on the occurrence of intracerebral hemorrhage. So that means I have to look at all the relevant factors that I can have in my cases and controls that I know are maybe related to deep and lobar ICH. And then I have to get those factors, and then I'm going to make sort of a scoring out of all these factors, and then match the cases and controls, the ICHs and non-ICHs, by that score. If you don't have good data, don't try that. If you don't have a big study, don't try it, because you need large samples to really make this work reasonably well. And then you find subgroups or subclasses or match pairs in which the treatment and control groups have balance, essentially the same distribution of observed covariates. It's not always possible to achieve the balance, and inferences can only be limited to subgroups where the balance is achieved. And this protocol specified analysis gives you the design to approximate a randomized trial. So you estimate the propensity score, you subclassify or match on this propensity scores by classes. And why does this work? Is because it creates balance in each subclass on all the covariates used in estimating the score. And it tries to do what's happening in a randomized trial. So that's kind of a newer technique. It's very popular. Be very careful about it. I'm not sure it's done well in many places. But you need big data. You need data that's very reliably collected in both cases and controls. You need the well-defined outcomes. You need well-defined variables. And you have to clearly define the variables that are of interest, let's say in the statins, for example. So, observational trials are often the most practical way of addressing hypotheses about association and risk. The major advantage is cost, and it's practical. The major limitation is bias, and it really addresses association more than causality. When you're entering a foreign country, as we came in today, as for me, you'd like to have a guide, which should be the statistician, unless you are one, and you've been to that country a lot before, a map, which is a good analysis plan, and the ability to speak the language, which is understanding concepts and limitations of the different trial designs we talked about. So, appreciate your time and be happy to answer any questions. Thank you.